Hi, my name is Elizabeth Hawes, and today I'm going to be presenting on the subject of the effect of polypharmacy on frailty in the geriatric population. Let me share my screen with you, and we will get started. In the geriatric population, defined as those older adults 65 years and above, multiple chronic diseases are common, requiring medication management. This often leads to polypharmacy or the use of several medications at one time. As you can see in this slide, these diseases, along with multi-morbidity, are found up into 98% of the geriatric population. Geriatrics have age-related changes in both pharmacodynamics and pharmacokinetics. This in turn leads to drug interactions, adverse drug events, and increased morbidity. Multiple studies link polypharmacy with another common geriatric condition, that of frailty. Frailty is a reversible condition, and therefore efforts need to be made to reduce its incidence. Polypharmacy. Unfortunately, there's no consistent number in the literature defining polypharmacy, but polypharmacy is commonly defined as routinely taking 5 or more medications. Polypharmacy is associated with negative consequences in the geriatric population. These negative consequences include a higher risk of medication non-adherence, drug interactions, drug events, and reduced functional capacity, including functional impairment, falls, and frailty. There's a strong link between the number of medications and medical comorbidity. It has been estimated that the majority of adults take at least one medication that is medically unnecessary. It has been noted that polypharmacy, independent of frailty, is associated with unexpected hospitalization, medication low adherence, and adverse drug events, which all contribute to the development of frailty. Frailty. Frailty is a medical condition characterized by the body's decreased ability to function, thus becoming more susceptible to stressors, which increases the potential for adverse health outcomes. Some of these adverse health outcomes include falls, hospitalization, higher healthcare costs, institutionalization, disability, and mortality, which are strongly linked to frailty. Frailty is multifactorial. Some of these factors include age-related decreased functional organ reserve, genetics, chronic disease, and environmental factors. Most often, the following 5 criteria are used when diagnosing frailty. These criteria include weakness, exhaustion, slow walking speed, decreased level of physical activity, and unintentional weight loss. An individual is considered frail when 3 or more of the criteria are present, and pre-frail when 1 or 2 of the criteria are present. Risk factors. Individually, the risk factors for both polypharmacy and frailty are being female and of an advanced age. Risk factors for those individuals taking 7 or more medications also tended to be female, less physically active, poor, and of advanced age. Statistical evidence. Multiple studies show evidence of how polypharmacy affects frailty. One such study conducted by Bonaga and others showed, quote, participants who met polypharmacy criteria were 40.2% in non-frail, 63.5% in pre-frail, and 81.9% in frail groups, end of quote. It's interesting to note how the percentage of polypharmacy increases as frailty increases. Another study by Vernice and others showed that, quote, participants using 4 to 6 medications had a higher risk of frailty of 55%, whereas those using more than 7 drugs were almost at 150% increased risk of frailty, end of quote. There is an increased risk of frailty related to each additional medication routinely consumed, which suggests a dose-response relationship. Similarly, Rosted and others found that, quote, when the number of medications increases by 1, the risk of being frail increases by 27%, and the risk of early death increases by 15%, end of quote. Adverse health outcomes. Polypharmacy affects frailty, and together they determine the frequency of health-related adverse events. Polypharmacy and frailty individually are related to visiting the emergency department, hospitalization, incident disability, and mortality, but together the incident rate increases. When polypharmacy and frailty are combined, the risk of dying actually increases by 6-fold. Interestingly, polypharmacy in the non-frail population does not increase the risk of adverse events, but does in the pre-frail and frail populations. Other adverse health outcomes, such as longer hospital stays, higher readmission rates at 30 and 90 days, as well as more discharges to nursing homes, are associated with those of the geriatric population with polypharmacy and frailty. Rosted and others found that, quote, frail patients with polypharmacy were 5 times more likely to be readmitted at 30 days and almost 8 times more likely to be admitted at 90 days, end of quote. Interventions for reduction. So how do we reduce polypharmacy and make it disappear? One obvious intervention is to review medications. Using appropriate prescribing practices and the use of adherence tools are also important interventions in reducing polypharmacy. One adherence tool, such as Stop-Start, screening tool of older people's prescriptions, and screening tool to alert to the right treatment, has 27 guidelines to address potentially inappropriate medications in the frail geriatric population. When Stop-Start is used in the first 72 hours of hospital admission, there's a 9% decrease in adverse drug events and a 3-day reduction in the hospital length of stay. The World Health Organization also recognizes the need to focus on polypharmacy and medication safety. Another adherence tool, the National Polypharmacy Program, which evaluates unnecessary medications, as well as an initiative called Stimulating Innovation Management of Polypharmacy and Adherence in the Elderly, or acronym Sympathy, is being trialed throughout Europe to promote best practices among governments and clinicians. So what else can be done to minimize polypharmacy and frailty? Most literature agrees that there needs to be a comprehensive geriatric assessment tool developed and used, as well as additional studies done to research the pathogenic rationale between polypharmacy and frailty, as well as analyze the effect of the various drug classifications linked with frailty. Last but not least, patient education, acceptance, and involvement of the primary care practitioner is critical in reducing the effect of polypharmacy on frailty. In conclusion, as mentioned previously, polypharmacy affects frailty by increasing the risk of frailty, including a dose-response relationship. Polypharmacy and frailty together increase the rate of incidence of adverse health-related events, and additional negative outcomes, including longer hospitalization, increased risk of readmission within 30 days and 90 days, as well as increased risk of being institutionalized after hospitalization are prevalent. An intervention plan to reduce medications, along with a comprehensive geriatric assessment tool, is key in reducing polypharmacy in the geriatric population. Any questions, comments? Thank you for listening today.